Dr. Latha Alaparthi, thank you so much for joining me today, and I welcome you to our conversation.
Thank you. Thanks for having me.
You are a part of the Gastroenterology Center of Connecticut and also the Vice President of DHPA, Digestive Health Physicians Association. So I want to begin by asking you to share a little bit about your practice.
Thank you again, Praveen, for having me. And I've listened to some of the other speakers on this, and it's very informative. So I hope I can be useful to whoever's tapping into this. So I joined the group in 2001. I actually met the then program director as part of my program at Yale New Haven, who was actually one of the three physician groups that founded this company, Gastroenterology Center of Connecticut. So he recruited me to the group, and I've been with the group since 2001. And so the group has grown from a 3-member group. By the time I joined, it was a 7-member group. I was the 7th person. And it is now at 13, and soon to have 3 new physicians joining from different parts of the country, including one of them being a Yale fellow, New York, and one that's transitioning from California to us. So it's been, and we've had some physicians that joined and moved to different parts of the country, but we are at 13 at this point with 3 more joining us in Connecticut.
Okay. And I know that, there is a relationship between GCC, which is Gastroenterology Center of Connecticut, and the group that is called as PACT, Physicians Alliance. Can you clarify what the relationship is?
Sure. Gastroenterology Center of Connecticut was a independent PC during its whole since founding until 2013, when it became part of the multispecialty group. We've had a close affiliation with the Yale hospitals in terms of admitting our patients, taking care of our patients, and teaching obligations and appointments. And in 2012, around that time, it became clear that many hospitals, including Yale, were acquiring primary care groups in the area, which was troubling to us. And it was troubling because that's how we get our referrals. And one of the things we wanted to do was make sure we stabilized our referral base. And one of the founding members, along with a few in the community, decided to brainstorm forming a group that allows us to remain independent and secure at least part of our referral base. Not all of it, but at least a good part of our referral base, so we don't feel so threatened.
Did that happen? Did you secure your referral base?
Definitely, it has made us feel more secure. As I said before, it is not all of our referrals coming from this group, but majority do, and it definitely helps us in terms of feeling more secure.
Mm-hmm, mm-hmm. So this is a multi-specialty group versus a single specialty group. What are the pros and cons of being in a multi-specialty environment as a gastroenterologist versus being in a large single specialty group?
So when PACT formed, it had internal medicine group, gastroenterology, nephrology in the beginning, and then a surgical group joined our group, and then more recently, orthopedics. And so majority of the physicians were internal medicine. And the way the group was formed is to make sure that the primary care physicians were always given enough of a voice to impact the long-term process of the company, because that was really our main intention, is to make sure that they were stabilized in order to help us stay secure with our referral base. So initial issues with the company were just really learning to work with multiple physicians rather than running our own company. And so if you can think of running a GI group versus a primary care group, they're completely different. So when you're forming an MSO, a billing group, that now has to cater to not only colonoscopy codes, but also nursing home codes, that becomes a challenge. So there was a significant amount of learning in that perspective. And plus the electronic medical record system had to be catered to different types of visits. And so all that posed its own challenges. So those are the main, I would say, challenges in learning to work with other physicians. But in general, we learned a lot, definitely in the first 4 or 5 years. Everything from day-to-day visits to navigating through HR to billing, EMR, everything was, we had to almost start from scratch and build it up.
How did you manage, dividing up the costs and responsibilities? Because it's, like you said, it's two different worlds. GI as a specialty is procedure driven. Primary care as a specialty is not as procedure driven. So the earnings are different. So how did you figure out how to work on the costs of the MSO?
So MSO is based on a fee structure, and the fee is the same. Our endoscopy center is not part of PACT. It's actually completely separate from the medical practice. And it is still a physician, very much a physician-owned entity. We have currently 4-room ASC in 2 different locations of our practice. So in terms of the cost allocations, in the beginning, there was a little bit of a give and take. Some units needed more help in certain areas and not others, and vice versa. So in the end, I feel it was a trade-off. Then some groups, for example, the primary care groups were on paper charts and they had to convert to EHR completely. So they took a significant amount of time in the beginning. But in terms of this individual cost allocations, it's all completely kept separate.
You've recently made a big decision to join Hartford Medical Group and Hartford HealthCare Medical Group. That's a seat change from probably the existing structure or any of your previous structures. So I was curious to know, how did you go about your decision and the story behind that?
That's a very good question and a tough one to answer in a small, time format, but I'll do my best. We historically, as you can think of, we are in the greater New Haven area from Milford, catering to Milford, New Haven suburbs, and into the Guilford, Brantford area along the shoreline. So historically, our practice has always been at the Yale New Haven entities. And we still are very much affiliated. We have teaching affiliations. We have leadership positions at the Yale New Haven Hospital. What became clear for PACT is for it to align with an entity that would allow us to remain independent. And what PACT has been able to secure at this point is an ability to continue to remain independent with our structure and MSO intact. So what we've done is to create a professional service agreement that allows us to remain independent. And I'm really hoping that this is a structure that will be alive for many years to come, because I think it's very important for groups like ourselves who fiercely protect their independence to remain so.
Did Hartford have similar agreements with any other group in the region?
Well, as I understand, there are PSAs with groups, but this is their first and only MSA.
The reason that I asked that question is I wondered if you had a template or they had a template that they followed, or are you familiar with similar arrangements in other parts of the country that you said, okay, they've done it this way, we can follow them?
Apparently not for the MSA. There have been templates within the state for PSAs, and they followed that to a large degree, but the MSA was unique.
Practically speaking, how does this all work? Does life look the same or does it look different?
As of right now, not much of a difference, except for the change in our way we address ourselves when we pick up the phone. That's been one of the major changes, which we have changed our name effectively from July 1st to PACT Gastroenterology Center, part of Hartford HealthCare Medical Group. Obviously, that becomes a long introduction, so we introduce ourselves as PACT Gastroenterology Center. In terms of the day-to-day work, not much has changed, but there's a significant amount of work ongoing to see where we need to make changes. And one of the big things that any company that's venturing into something like this looks for is to make their footprint known. And I believe Hartford HealthCare is no different, and understandably so. So there will definitely be more of a presence in terms of logos and signs and signage that will change in the next few weeks.
How did you navigate the competitive landscape while making this decision with respect to other hospitals, which I'm sure you're close to, and so on?
It's a tough one. And I've said this to many of my colleagues. And as a physician that is very passionate about what I do and the care that I provide for my patients, and really respecting my independence and wanting to practice the way we feel is best, it's been a tough one to to kind of navigate and make sure that we are allowed that freedom as we go forward. And to that end, we've had to be very open and discuss this very clearly with all sides. So historically, as I mentioned, and I trained at Yale, so it's my fellowship mentor, and I know many people from that area, and we work very closely. And at the same time, we decided what's best for us is to align ourselves with Hartford HealthCare Medical Group for the prior reasons mentioned. And so we've been very open, both sides, stating that we will do what's best for our patients, and we'll send our patients where they are best cared for and where they feel comfortable. So to that end, I really don't care for feeling like a pawn in a territorial situations in states. And I'm really hoping that both sides will respect that, and we will continue to, I mean, it's early stages, but what we are led to believe at this time and the conversations we've had, I don't believe will really force us to change anything. Both sides have been very accepting and very open in allowing us to be who we are and actually respect us for who we are.
Would this arrangement be restrictive for you to go see patients at Yale, or there's nothing like that?
No. In fact, we in one of the smaller hospitals, Milford, we're the only GI group. We have a very much of a presence. It's a small hospital. I used to be a president of medical staff before it became part of a Yale healthcare system. Now it's part of a Bridgeport hospital, which is Yale healthcare system, and still the chief of GI there. So we have, and my colleague David Haas is a chief of GI at St. Raphael campus. We have leadership positions. I'm on the medical executive board of Yale New Haven Medical Practice. So we have presence at Yale, and I do not believe that it will change the way we practice. And I really hope it doesn't come down to that, because then I would have to fight for what's right for my patients.
Okay. I'll get to COVID now. Connecticut was one of the earliest affected states, when COVID hit. How did you navigate the pandemic, and how are things going now?
When COVID was sort of erupting in the New York region, we were finishing up or wrapping up our DHPA meeting in DC. The last day of our meeting was very interesting. We had several meetings. I believe, 12 meetings at the congressional offices and Senate offices, and dwindled down to about 3 meetings. And at the end of the day, we weren't even sure we would take our train back because of the New Rochelle shutdown, because the train Amtrak goes through New Rochelle. It was very interesting, the whole evolution of that. One of the physicians that was first diagnosed, or people that was first diagnosed with COVID in Bridgeport Hospital, was a New Rochelle physician, a physician that lived in New Rochelle but practiced in Bridgeport, who unfortunately has since passed. He is a pulmonologist. So that's how things began for us. And the first few weeks were surreal. And I went from having a normal office day, or at least seemingly normal office day, that Monday after we returned, to within 2 days to going to a complete shutdown. and having to change all of our patients that were on schedule for endoscopies, telling them we don't know when we'll be open again. One of the things we did early on is to try and switch to telehealth. We had been doing telehealth in terms of telemedicine, phone calls. Prior to that, I was one of the few physicians that was using it in my office. But we soon transitioned to telehealth. And at that point, the biggest crunch was trying to find the right platform to offer telehealth to our patients that was easy to understand and was reliable in terms of connectivity. And then the endoscopy center, that was a huge issue. There was so much unknown. What we could only fall back on were the experiences from Wuhan, because we didn't have any in our country at that time. We were one of the few ASCs that didn't completely shut down, but we had about 5% of patients coming in per week, those that absolutely needed their procedures and could not be or should not be done in the hospitals for the reasons of COVID. We took extreme precautions with an hour in between patients and such to just make sure that those individuals were able to get through their procedures. And since the opening, it has been a whole new paradigm. While we were in the first 2 weeks of shutdown, I quickly got thinking about we will need to open our ASC some point down the road when COVID is still here. We can't be shut down forever, and we have an obligation to offer these procedures and diagnose patients in timely manner, colon cancer screening. So I came up with a format that I thought at the time made sense, because I was very excited about the antibody testing, which obviously has not panned out as we expected. And I presented it to a few people at DHPA exec team, and to one of the physicians that is also a DHPA member that's on AGA leadership. And there was a significant amount of interest, and then that led us to working with the AGA, DHPA, and developing that joint guidance along with all of us involved, which was a very relevant practical step for us, and still to this day is being used.
In the patient standpoint, what kind of change did you notice? Like, so were they as open to come into the ASC? I know you restarted it, but what is the sentiment right now?
Since we've reopened in the last 3-4 weeks, it's been a whole different paradigm shift. And now, because of the guidances and the increased number of cases, one of the major steps we take is testing everyone. We have developed a 10-day symptom log, not just temperature, other symptoms that can affect gastroenterology in specific, including bowel changes, etc. And we expect our patients to fill that symptom log and also have PCR testing within 72 hours of procedure. And so the testing, the tracking, reminding patients to keep their symptom log, and making sure that the results are in chart before they arrive for procedure or before they actually prep for the procedure has been a task of its own. And it's really put a strain on our staffing, which is suffering, which is a whole discussion in itself, added complexity to what we do every day. Mm-hmm. This is in addition to what we've done in the endoscopy center, which is a significant amount of cleaning in between procedures, and PPE that everyone is requested or recommended to wear.
Are you contact tracing post-procedure, and how are you doing that?
Fortunately, to date, we have not had anyone that has tested positive after the procedure. So we have not had to elicit that, but we do have a process thought through and in place as to how we would contact trace if that were the case. Mm-hmm. So what we do now is call patients week to 10 days out and make sure that they have not had any new symptoms that are suspicious for COVID, and also instruct them to call us back if they develop any symptoms within the few weeks after procedure. Fortunately, we have not had any cases.
Okay, that's good to know. How has your staff taken all this, and how are you managing that?
Yeah, that's a good question and tough one as well. Well, before I get on to that, I just want to let you know that between our group and CTGI, which is another major group in this state, we have tested over 1,000 patients, and we have only a handful of patients that have turned positive. Excuse me. That was in the beginning of the pandemic when the cases were still high, so it makes sense. And I believe our case rate was 0.02% or so at the time, or positive rate. So it has been very, very low in terms of the risk, and we continue to test everyone. Our staffing, due to the shutdown of business, we furloughed for a couple of weeks until the loans became a reality and we were able to bring back our staff. Few staff members went on FMLA or took unemployment because they just could not afford to come back because of young children. Because unlike many other companies that can work remotely, we cannot work remotely. We did stagger our staff when the social distancing was still a significant issue in Connecticut, and we quickly created HIPAA reliable home access to some of our patients that could room a patient for me to do telehealth. And so we had to do a significant amount of work around to make sure that everything was in place. As many people have said among my colleagues, we put on significantly higher number of hours as administrators to take care of fewer people in the pandemic time because of the number of workarounds and processes we had to recreate as we took care of our patients. As of right now, we still have a shortage, both on the practice side and in the endoscopy side, in the hospitals and in our endoscopy centers, because many nurses that were on the borderline thinking about retiring have decided to retire. And many with health issues have decided not to work for the right reasons. And many with childcare issues and other obligations have decided not to return. So it's significantly straining the ones that are in the mix and having to absorb work for other staff members that are not in the mix. And this is something that I am every single day trying to navigate through, including yesterday. Making sure that nothing that is associated with our patient care is compromised because of the shortages.
As a physician, you're putting yourself in risky situations and taking care of your patients. And then you come home and then you have to take care of yourself and your family. So how do you navigate, these two worlds of taking care of patients versus taking care of yourself? And I'm asking on behalf of all physicians, actually.
So it's like any other first responder or physician out there that is interfacing with the patients. I think many don't realize that we perform procedures that are aerosol generating, and that's one of the reasons our societies have come up with such stringent guidelines. For example, recently restarting a manometry or a motility study that we perform in our office, we had to come up with clear, stringent steps in terms of the precautions we take, not just for the patient, but for the nurse that performs the testing and for everyone that uses that room subsequently. And so yes, it is a real risk we take every single day in terms of the exposure. And one of the things we should always remember is to make sure that you think about yourself, because as it is apparent from the statistics and the deficits we are seeing, we are a very valuable commodity, and we need to make sure that we take care of ourselves to be able to continue to take care of our patients. So in that sense, we use the appropriate PPE. We make sure that we don't compromise on the steps we've put in place to make sure that the patients that are coming in are not high-risk patients. And the other aspects are to make sure that there are things that we have in place to relax, whatever it is that takes your mind off and just really takes you to a different sphere. Physical health, and of course, my pet peeve is ergonomics. Don't forget, despite the PPE, to ensure that you are taking care of all of the things that you need to establish in your endoscopy rooms to not physically strain yourself or hurt yourself.
So, Dr. Alaparthi, you're one of the few women physician leaders that I know of in GI. I have a twofold question here. One is how did you reach the role that you currently have? You play multiple roles. How did that happen? And the second more important question is uh, why is that the case? Why are there so few women leaders in gastroenterology and medicine as a whole?
Thanks for that question. I'll answer it the best I can with my own experience, and maybe the second one I can't answer fully, but I'll do my best. The first was really working with my office staff and really handling some of the challenges that became known to some of my peers and my senior physicians and administrators. Oh, she's good at this. And one, most of the times it was out of necessity. For example, I was extremely efficient with my schedules because of necessity. I had two young children at home, and I had to navigate through hospital rotations, seeing patients in the office, making sure my results were resulted back to the patients, etc. When they saw that the billings were at the same as some full-time physicians, they asked, how do you manage this? So I went into looking at everyone's schedules and started involving myself on making schedules efficient, really sitting down with the physicians and telling them how they can navigate through schedules. And some of the issues that came up on a day-to-day basis and how I could handle them diplomatically with the patient and the staff. That became known to some of my staff members, who then asked me to take on some leadership roles, which, like any female physician, I said no in the beginning because my children were still younger and in schools. And one of my administrators waited until I dropped off my younger daughter at college and met me the next day. And that's when I took over as the managing partner of our company. And it's basically like running a house. You look at every aspect of what you're doing on a day-to-day basis, and also business aspect of it, making sure that it is efficient, and every employee is taken care of, financial aspects are met with, and staying accountable to yourself and to your company. So one of the things also that does is to really engulf you in the number of hours you have to put into the company. So my involvement was a slow trajectory, and before I became a managing partner, I was a president of medical staff, just being involved in medical staff at the local hospital, chief of GI at that same local hospital. So I had been doing more leadership roles in the community and small leadership roles, and being involved in the executive committee of my company just to help. In terms of why there are fewer female physicians, especially in private practice, I can't answer for the past, but I do see many women rising into the roles at this point. And I'm hoping that they're able to see themselves as leaders and just as good at understanding the business aspects of the companies. I believe that's the part that many of us, men and women, don't really get a significant amount of exposure during training. But early on in the group, it's important to pay attention and to really get into the details and realize that it's not difficult to understand once you put your mind to it. And I'm hoping that that will change going forwards. As we know, the AAMC's data and my own daughter's med school class shows you that there are more female physicians and medical students now than in the past. And I believe this is a number that will continue to increase, and it's important to engage everyone into the leadership mix.
So my final question, Dr. Alaparthi, is what is the future of GI post-COVID?
I was thinking through, I think it's going to be technology. Patient care, patients still rely on us, and the stress increase recently has definitely worsened functional bowel diseases. I do think that we will focus a lot more on putting technology so we can take care of patients remotely and coming up with treatment algorithms that are slightly different from what they are at this point, and hopefully adapt some of the technology that's available, whether it's social media platforms or along the lines where we can address patients individually, but yet in a group, through platforms that are secure and are accessible to patients. So I think that this is going to be a new paradigm in future in trying to keep the social distancing, which I believe will be in place for at least the rest of the year, if not into next year.
To see happen if we fast forward 4 or 5 years from now?
So I was about to read a PillCam right before this, and I'm probably going to go back to reading it. And so I think we're going to try and look for platforms like that for diagnostic purposes, which are more wireless and remote, that can give us the view that we need. And for diagnostic purposes or therapeutic purposes, then we can intervene and be therapeutic in terms of interventions or procedures we perform and actually fix things. Home-based testing to some degree of the things that we do, including the PillCam type testing, will probably increase. Technology, I think we really need to focus on the platforms that we have. And one of the things, for example, every single day, even today, to this day, when I take care of patients, I sometimes have to have 3 EHRs open, which to me is so detrimental in terms of patient care. I really wish there was interoperability, and a lofty goal would be to have a single platform, but interoperability or ease of transitioning from one to the other, instead of having to print, scan, or import information from one to the other, to just so I have information in one place, I think is really affecting patient care. And the last would be to make sure that we have patients that have access to the platforms that we are putting in place. I was working with the fellows 2 days ago in one of the Yale GI clinics, and it was clear that several patients that otherwise would have had to take public transportation to come to clinics have really embraced the telehealth platform, and really appreciate the fact that the doctor will call them, go over the treatment options, and make sure that they've done their testing that is a very time-sensitive one, especially for inflammatory bowel disease, cirrhosis, hepatitis C, along the lines. And that's the population oftentimes that has least access to many of these platforms. So I feel we need to really keep our mind and eyes open to ensure that while we are innovating, that we're also making sure that people have access to them.
Mm-hmm. Dr. Alaparthi, thank you so much for all the insights. It's been tremendously educational for me, and I'm sure people who are watching this will feel the same. Was there anything else that you wanted to share before we close?
I think the challenges that we are facing as people, I really want people to know that each one of us are going through the same things about the COVID and the transition. But with the whole challenge has come the thought process, and it almost makes you feel like you can innovate because you have a challenge in front of you. And I'm hoping that we all embrace it and bring new ideas to the forefront and make them work.
Okay.
Thank you for having me.